Nel trattamento delle malattie reumatologiche, l'approccio treat to target ha rivoluzionato la gestione di molte patologie croniche infiammatorie, ma può essere applicato anche alla sindrome di Behçet, una malattia multisistemica complessa e imprevedibile. Ne abbiamo parlato con la professoressa Gulen Hatemi, in occasione dei lavori del sesto corso EUVAS sulle vasculiti in corso a Trieste. Professoressa Hatemi, cosa è la sindrome di Behçet?
Behçet syndrome is a multi-system variable vessel vasculitis. So what we mean by multi-system is that patients have very heterogeneous clinical findings. Some of the patients only have oral genital ulcers, papulopustular and nodular skin lesions and joint involvement. And some patients, in addition to these mucocutaneous lesions, may have uveitis, gastrointestinal involvement, central nervous system involvement, and venous or arterial involvement. This is a type of vasculitis that follows a course with relapses and remissions.
Ecco, allora cosa significa applicare un approccio treat to target nella gestione della malattia e quali sono gli obiettivi terapeutici realistici per i diversi fenotipi?
Yeah. So this treat to target strategy has already worked very well in many diseases, including diabetes mellitus and hypertension. And when they were actually started to be worked on in rheumatology, rheumatoid arthritis and lupus are good examples where treat to target strategies have worked. So in a treat to target strategy, you should be defining your long-term goal, your long-term aim, and then you should be determining short-term targets, attainment of which would predict a good long-term outcome, reaching your long-term goal. And in Behçet syndrome, it has been a bit challenging because of the heterogeneous clinical findings of Behçet syndrome. And the long-term goal may not be the same for each patient. What I mean by that is for patients with organ involvement, such as uveitis, vascular, gastrointestinal, or central nervous system involvement, the long-term goal is obtaining complete remission. You want the disease to be gone, and you don't want any relapses. On the other hand, for patients who have only skin, mucosa, and joint involvement, there can be a level of low disease activity, a minimal disease activity that is acceptable for the patients. Because obtaining a complete remission is not very easy in patients with mucocutaneous involvement, and sometimes when trying to obtain complete remission, you have to be giving more immune suppressives than needed, and you may be actually risking the patient with adverse events when trying to reach complete remission. And many patients are happy with a low disease of activity. So the treatment goals may be different depending on the organ and the system that is involved.
Professoressa, ci sono degli strumenti validati per monitorare in modo standardizzato l'attività di malattia e guidare le scelte terapeutiche?
Well, outcome measures in Behçet syndrome are, again, challenging. I mean, there are several hundreds of outcome measures that were developed for Behçet syndrome or that were borrowed from other similar diseases, such as Crohn's disease for gastrointestinal Behçets. However, actually, many of them are not ideal, are not optimal. For overall disease assessment, for disease activity assessment, there are a number of instruments that are used. The most frequently used one is the Behçet disease current activity form. Other than that, there is Behçet syndrome activity scale, and there is IBDAM, and there is a clinical severity index. Among these, the most frequently used and the best validated, I would say, is the Behçet disease current activity form. So we know that it has good construct validity, it has intra-observer, inter-observer reliability, it is sensitive to change, and it has been shown to have good trial discrimination. But the problem is that it doesn't have weighting. So a patient with only oral ulcers has 1 point, as well as a patient with sight-threatening uveitis. So that is one of the most critical issues about a Behçet disease current activity index.
Ecco, in conclusione, professoressa Hatemi, quali sono le strategie ottimali di trattamento per le diverse manifestazioni di malattia di Behçet?
Yeah. For patients who have skin, mucosa, and joint involvement, we usually start with colchicine together with topical agents, topical corticosteroids, topical antibiotics if needed. And if the patients are refractory, then we can go on to using apremilast or a biologic such as a TNF inhibitor. On the other hand, in patients who have organ involvement, we usually start with immune suppressives upfront because these organ involvements have a high risk of leaving damage. So in severe patients, we usually start with a monoclonal TNF inhibitor. It could be infliximab or adalimumab. More milder patients or patients who have been in remission for a long time can be treated with conventional immune suppressives such as azathioprine. And in even patients who we started with TNF inhibitors, after a while, if they are in remission, then we can have maintenance treatment with conventional immunosuppressives such as azathioprine. And in patients who are refractory to TNF inhibitors, some of the other treatment modalities that have been tried are IL-23 inhibitors such as ustekinumab, IL-17 inhibitors secukinumab, and more recently JAK inhibitors have been tried for the management of Behçet syndrome.